I'd like to talk a little bit now from the perspective of a residency program director and surgical educator about how I would see us incorporating a tool like you've heard described in some good detail this morning into resident education. I have nothing to disclose. Some of this is very basic and will be well known to this audience, but I just want to briefly look at this from an educator's perspective. And one of the things that we all have learned, some of us the hard way, is that as we teach adults and adult learners, which is certainly our resident population, there are basic principles of learning that govern how that group acquires new knowledge and applies it that are very different from the things that we all learned in our school background when our brains were a little bit more like sponges. And the critical features that have been identified across a number of different ways of looking at this are adult learners require relevance. There has to be some immediacy to the learning. They have to be able to apply what they're learning in the near time frame. They have to be participatory learners, not just as we're doing today, sitting listening to us talk, but engaged in the learning process, especially so with technical skill development. They're heavily reliant on feedback, both in reinforcing positive behaviors and in correcting things that are not conducive to their continued learning. And they do function best in the safe learning environment, and I always laugh at this when I think about most of our surgical training backgrounds. But as Jeff Ponsky said when I was training, a little anxiety is a good thing, and that's true actually in research. It heightens one's attention, but a lot of anxiety and pressure is actually defeating from a learning standpoint. So those are the basic principles we want to think about as we think about how to train our residents. As far as what this means, it means that we have to train people in an area where there's a realistic possibility that they're going to be able to apply it in their practice. And I think as you listen to Sam's talk and Imran's talk and other talks this morning, it's very clear, and Maury's talk, that this is something that our residents need to be able to apply as they move into their clinical careers. And they will learn best if we can provide them with a rehearsal setting that'll be individually paced. They won't all learn at the same pace. That'll be a safe environment for them to practice in. We've learned a lot in recent years about patient safety and the appropriate concern patients and third-party payers have about the learning environment as we train people. They need to be, again, participatory and hands-on, and ideally, there's a progressive or scaffolded approach to how that's done, so that early in their training, a lot of external structure and reinforcement are applied, and as they become more senior learners, we back away, and they begin to function more and more independently. Absent that, they may become expert at executing exactly what we tell them, but hit a real wall when they try to move into independent practice themselves after leaving the training program. And that's a real problem, I think, in the era we're in. Compared to some of the time frames that some of us trained in. And the other thing to think about is that when they are involved in activities that involve a support team or team dynamics, as so much of surgery does, and certainly complex endoscopy procedures are in that category, training with their team and training so that team dynamics and team interactions can be part of the training environment become increasingly important. If I take a brief non-medical example to illustrate this, I spent some time in Augusta, Georgia, and we'll be seeing lots of pictures like this in coming weeks if you watch the Masters. And obviously the goal of training is to reach a true level of mastery. But in fact, if you took me to Augusta National and turned me loose and said, have at it, have a good time, learn something, I would be hazardous to the course, I'd be hazardous to the people around me. And I'd probably fall back on my usual way of keeping score, which is +1 means I found one more ball than I lost. The point is that that's really a lot of how we've trained surgeons over the years. We thrust them into a high-performance environment and tell them to learn. We throw them into the deep end of the pool, and that creates excessive time and performance pressures. It can easily lead to non-participatory didactic programs where we try to quickly reinforce things by telling them, go read this, go watch this. And it really doesn't tie into these adult learning principles that I've been emphasizing. And in fact, if we also don't train them in a way that's immediately applicable or follows this principle of immediacy, and participatory learning, there can be some very bad learning outcomes. And we've actually seen that as a profession when we looked at what happened when laparoscopic cholecystectomy hit and the common bile duct injury spike, or if you look at laparoscopic colectomy when it first hit, and the number of local recurrences in violation of oncologic principles as people tried to accomplish something without following well standardized principles of surgical performance. So all these things are things we need to weigh heavily as we think about how to train our residents. I want to throw out one of the common learning modules, again, just as a background to how we might apply these things. And again, this is something I'm sure many in this audience are very familiar with, but it'll help to set up something I want to say later about where I think FES can fit into the continuum of learning. And Kopta, following Fitz and Posner, who originally published this in a non-medical area, said there were three basic areas to skill acquisition. The first is a cognitive phase, where the learner builds a mental model of the task and does this by watching other performances, listening, reading. And if you try to ask them to perform the task during this phase, it'll be like the first time you took your 16-year-old out in the car. It'll be erratic. It'll be which way do I flip which switch to signal or to do what I want to do. And they have to compartmentalize the task. There was a beautiful discussion Brian gave about deconstructive thinking in teaching tasks. And at the learner, if we don't do this for them at the start, we'll have to do it themselves. And it'll make their performance erratic and sort of Parkinsonian, if you will. And then the second phase is an integrative phase. And really the key foundation of this is an opportunity for disciplined practice. And in that setting, with feedback, again, about the performance and how to improve and correct, the performance becomes more fluid and there are fewer interruptions or breakdowns. And then ultimately, it's, if you use the car driving example I was alluding to a moment ago, it gets to the point, like it would be true for this audience, where you can drive home from work and never think about what you're doing in the car the entire time and all of a sudden find yourself in your driveway. And that's the level of performance we would like to get to. Now, how do we ask our learners to accomplish these tasks? And there's several things that we've learned about practice and skill development that I think pertain to this discussion. One is that there has to be an opportunity for self-reflection and articulation of the skill as they're developing the task. And if you look at high-level performers like athletes who perform at very high professional levels, this is something that many of them practice as a discipline. I often would marvel at watching someone like Michael Jordan play basketball and the things he would do that seemed creative and fluid and without much forethought. And he had a discipline the night before a game. He would actually rehearse different things he might do in different situations mentally, and sort of created mental models that allowed him to do things more automatically than he would if he had to think about it as he was reacting in the game performance situation. The other thing we've learned is that the more complex the task, the more observations are necessary in building the model. But if you make those observations too diverse, it can be confusing, especially to the novice learner. So being careful how we provide them information that really cues them into the important elements and doesn't confuse them with unnecessary detail is an important part of the design. When they practice, having to rebuild the mental model is very helpful in their growth and development. So, you know, when I trained, I remember we used to say, boy, a great day to learn hernia repairs is if you do 5 hernia repairs in a row. And that may be true in terms of going through the motions again and again, but what starts to happen about the third time is you're doing it because you just did it and not because you understand the mental construct of why you're doing it that way. So if you can structure practice so that they have to shift gears with different components of the task and mentally rebuild the model, they'll retain that much better. Finally, when they practice skills, we all do best in the morning or after rest. If we go beyond 4 hours, you'll see this if you watch Wimbledon. You'll see an outstanding person, and 4 hours into a 5-set match, all of a sudden one of the competitors will just break down. And fatigue is a real issue, so avoiding very prolonged periods of practice. And then again, the principles I've already mentioned of hands-on involvement of the teacher. We'll come back to that in a little bit. So where would FES fit into this kind of model as I think as a surgical educator, as I think as a program director, about how we equip people with new skills? Well, actually, there's a number of ways we can do this, and listed on this slide are some of the ways I've thought about helping someone build endoscopic skill. And you can see that FES really offers us the opportunity to leverage a lot of the early part of this sort of graduated curve for how to teach skills. The thing that I want to emphasize here is that tools don't replace the relational aspect of teaching and learning, and this is good news for those of us that like the teaching environment. And there are a couple studies that have been done by one of my colleagues at SIU, David Rogers, looked at this, and I'm not going to belabor it in the interest of time, but he basically showed that when you use tools like computer or video-based modules, that the best learning occurs not with that alone, but when it's cued or proctored or guided by a teacher who is more expert. And the other thing to remember is that we're orienting what we're doing here in this discussion to the novice learner. We don't know a lot about how to help experts leverage their skill to a newer level, and issues of fidelity in the tools play a bigger role perhaps there than they do for the learners we're focusing on today as we think about resident education. Again, these are the studies I mentioned, and I'm not going to belabor these points in the interest of time, but we don't want to throw the baby out with the bathwater. Having good tools does not replace the importance of an expert teacher involved in the process, reinforcing, guiding, and cueing, especially with a beginning learner. Now, when we think, Ted showed nicely some of the things that can be used apart from the kind of curriculum and testing tool that we've developed here with FES. And when are they most important? Well, these are some of the areas in endoscopy where I think as an educator you ought to think about incorporating these kind of elements, because they're harder to teach on a purely simulated platform. If you want real tissue handling and haptic capabilities, if you want to rehearse a team event, if you want to learn how to manage a complication and be able to simulate that, in these kind of settings, we will need to use animal or cadaver lab type experiences. So there's a place for each of these steps, each of these tools, and the best training program will incorporate all of the above depending what we're trying to teach the learner at that step in their development. The other thing is Todd Hedeford has shown that if you do a short course mentality, so let's say you set up a weekday curriculum in your skills lab using something like the STEP tools to help your residents gather some endoscopic skill, if they can have some precepted or proctored experience soon thereafter with that same skill and its application in the clinical setting, it probably will help them retain that skill much better than if the next time they pick up a scope is when some skills lab is again put on for them. And tapping into rural surgery resources, a lot of program directors have struggled with how do I get my residents an experience. Maybe they don't have a good relationship with their GI colleagues. Maybe they don't have surgeons on their staff that are doing much endoscopy. Remembering that there are resources in rural surgery, and some of you have heard Jeff Ponsky tell the story of how he got his original training in endoscopy by finding a gastroenterologist in a smaller community because no one would teach him at the time where he was in his training program. So learning to use these resources, again, in the continuum of learning that our students require. A lot of thought went into the development of FES and what are the core skills, and you saw a very nice outline from Brian of what the deconstructed tasks were, and Jeff is going to show us shortly what those modules look like in the FES testing platform. But this list will continue to grow in our lifetime, and I think it's useful as teachers to take a step back and say, what are the skill sets I need to help them acquire, and then which training tool, be it a simulated model, be it a desktop training environment, be it an animal lab, be it a cadaver lab, be it an explant, where can I best teach this technique? And try not to leave out major holes in what the resident will need in order to be a really well-trained beginning endoscopist. So if I take Kopta's model, again, thinking as an educator, and look at the sequence, and ask what steps in the process could best be addressed with different learning tools, and I've outlined those at the bottom of the slide for each of these steps that Kopta has given us. I think you'll see that FES really offers the potential to strongly leverage the beginning part of this curve, and not just with tools, but with validated tools, as you've heard, I think, repeatedly through this program this morning. The other thing I think that's especially important for us to be reminded of, thinking of this from an educational standpoint as surgeons, is the common rap against surgeons is they view endoscopy as simply a technical maneuver. I reached the cecum, I won the prize. And to remember that we need to help our residents build the cognitive set of disease understanding in order to appropriately apply this and be credible with their gastroenterology colleagues as real GI providers. There are many tools now, atlases, online atlases like the Dave site that many of you I'm sure are familiar with, where we have great tools for them to do this. When I was a fellow, Jeff Ponsky, and I'm sure he did this for many other members of the panel this morning that spent time with him, gave me an atlas and said, you won't see everything during your fellowship, but if you spend time in this book, you will learn to recognize these pathologies, and that's an important part of your learning, not just learning to maneuver the scope. Wanted to close, and some of this has been alluded to already, with just a couple comments. Jerry Freed, in his presidential address at the Central Surgical just last week, talked about the importance of education in innovation. And one of the points he made was that when we introduce new technologies, the educational component is a key component of ethically applying it. And when we think about some of the things, even as have been alluded to in other talks this morning with the new endoscopic treatments for reflux disease and some of the patient deaths that occurred, a lot of them, if you look back at it, were linked to how the technique was promulgated and educational principles were followed or not followed in how it was disseminated into the practicing community. So it's an ethical thing that we need to consider, and being good on the educational end is a very important part of being innovators in medical care. This slide was shown already, so I'm not going to belabor this point again in the interest of time, but just to say that in this study that the McGill Group produced, looking at the FLS platform and a validated clinical assessment tool, such as we now have, and as Brian described with gauges, they were able to show that you could basically take a PG1 resident and accelerate them to a mid-level, say PG3 resident, by a simple training program in terms of their technical skill as measured in the clinical setting that cost them 7 hours of training in the lab to a level of proficiency that people like Matt and Danny Scott helped identify, as Matt alluded to in his talk. And 5 of the 7.5 hours in that study that the residents spent were unproctored. So I think this really shows us what tools like FLS and FES could potentially do to accelerate the clinical capabilities and certainly the technical abilities and cognitive framework for our trainees. So how would I conclude this? How would I put all this together as a program director? Well, I think it depends. Yeah, I think we want to train them, and just like everything else we do, in the continuum, in a continuum from the early residency years through the end. You don't solve all this by taking a PG 4 or 5, as so often happens now and happens in my program, so true confession, and say, get your numbers, and they're hustling around in the last 6 months of their chief year to do a few colonoscopies. I think the way that we would really do this well would be to start at the PG1 level and have them do labs, and we do this at our place where they get exposure to basic endoscopic instrumentation. They start to familiarize themselves with GI pathology as seen through a scope using online atlases, and begin maybe some recreational practice activities with some of the game-like things that you've seen today and that are available in a variety of formats. In their second, third year level, FES could play, I think, a huge role, both cognitively and technically, of helping them leverage their development, and ideally in a preclinical setting, followed soon thereafter, again with this principle of immediacy, by letting them start to engage in clinical experience. A great place for them to start doing that is in the operating room with operative endoscopies that are part of so many of the procedures we do nowadays. There's also some wonderful resident courses and webinars that are available at very low cost, or in some cases entirely paid for, that SAGES offers, and many of you are aware of. And maybe also a dedicated rotation can help them get sort of a clustered experience as they start to develop their skill. And then in their 4th and 5th years, begin to focus more and more on therapeutic events, even ERCP. Most of our residents won't do ERCP. I think it's typically something they're going to have to do a fellowship to do. But we did a study, Dave Shears and one of our other colleagues and I did a study years ago that showed that you could immediately involve residents in ERCP, even letting them do much of the procedure, and the outcomes could be similar to cases in which there was no resident involvement. And then finally, at the senior level, I think it's great for them to spend some time with gastroenterologists and cross-train. And those of you who heard David Mavi's presidential address at SSAT, it's in the Journal of Gastrointestinal Surgery, talking about the era we're moving into and the real GI specialist being much broader than the typical specialty limits that we've thought of. This ties in all very well, by the way, with what's happening in GME with milestones. I think the FES program offers the potential to be a critical milestone in the development of resident endoscopic skill. So I'm going to stop there. I think FES, as you've seen it presented this morning, from an educator's point of view, offers the most refined and validated instrument we have, and it can help us standardize, accelerate, and leverage resident skill in a way that will really help prepare them for the workforce they're going into in years to come. I'm going to welcome now to the podium Jeff Marks.